So babies that are born less than 5 pounds 8 ounces sometimes are classified as well as SGA. And again, these babies may be small for issues of blood flow to and from the baby in utero, or conditions such as mom's nutrition, if mom smoked or used drugs, if she had high blood pressure, or conditions such as diabetes, or exposed to an infection in uterine and the intrauterine life. This baby can be small for gestational age, and there can be other conditions based on the conditions we talked about in class. When you look at the characteristics of SGA babies, again, some of their characteristics may be similar to babies who are IUGR. You can have a small baby. A baby who's IUGR, you may, in addition to, have sunken, kind of a scaphoid type of abdomen. They may have wider suture lines, a thin umbilical cord. That may be the same case you see on an SGA baby as well. Babies that are IUGR, you may see a baby whose head is larger than their body. Their extremities may appear to be wasted, and they have reduced fat stores, which babies who are small for gestational age may also have reduced fat stores as well. When you're looking at the nursing management of the SGA baby, again, I told you some of these may be similar to the IUGR baby as well. You're going to want to initiate early and frequent feedings. Hopefully they're oral. If they're not, we'll talk about gavage feedings as we progress a little bit later in this content. You're going to monitor them as per hospital protocol for hypoglycemia, or if you feel or see symptoms of that you think their blood sugar is low, you're going to assess for that. They may have dextrose added to their IV infusions if they're unable to maintain their glucose level. They're going to weigh them every day. Again, we're going to promote periods of rest to decrease the workload and metabolic requirements for their body, and we're going to monitor them for polycythemia. When you're speaking specific to the baby who's IUGR, now I talked about SGA and IUGR a couple slides ago, but when I'm speaking specifically to IUGR, this baby is not meeting the growth patterns that are normally expected. And this can be before birth, and this can be a pathologic problem. A lot of times, again, it's problems prior to birth, such as oxygenated blood flow that is decreased to this fetus before the baby's born. The baby may have an increased risk of being born with meconium aspiration. They may have erythrocytosis, which is increase of red blood cells. They also may have problems regulating their blood sugar. And what you're going to see with these babies in particular is they don't always meet their developmental markers. A lot of times they're playing catch up. You learned about the developmental markers in your pediatric content, especially the information learned in the newborn period, and sometimes these babies don't meet those developmental markers on time. They're a lot of times playing catch up. I said to you that this could be due to blood flow issues, and this is an example of a normal placenta and the placenta of a baby who was born and classified as being IUGR. You'll note that the placenta is smaller, and in some research studies, it's saying that the umbilical cord is thinner. Some research studies also look at the fetal surface of the placenta in babies that are IUGR. Now, we talked about this when we talked about the placenta of a smoker. Obviously, that can lead to a baby being born SGA, IUGR, and having intrauterine growth restriction, amongst other problems. We know that from 28 weeks to 38 weeks, the baby's growth meets very specific markers and they continue to grow. But babies that have IUGR or are classified at IUGR may not meet those growth markers. Again, maternal factors, disease, environmental factors, placental factors, and fetal factors can bring us to this table. There's different types of IUGR. There's three main types that I present to you. You have symmetrical, asymmetrical, and intermediate. When you look at asymmetrical, or excuse me, when you look at symmetrical, it's usually related to intrauterine growth, intrauterine infections, torque infections, chromosomal disorders, and congenital malformations. Now, I've showed on this picture here, I'm showing you a normal presenting fetus with a normal head and normal abdomen, and I'm showing you what IUGR is. So you have symmetrical and asymmetrical, and you can have intermediate. So I just presented symmetrical to you. Let's talk about asymmetrical. And what you're going to see with this particular type of IUGR, it's a restriction of nutrient supply. So you can have conditions that cause uteroplacental insufficiency, maternal diseases, chronic diseases, renal diseases, high blood pressure, vascular disease. And usually this particular problem starts to affect the baby after 28 weeks of gestation. So they'll have the normal head growth, the normal abdominal growth, but decreased distribution of blood flow. So they'll have a smaller liver, decreased glycogen stores, chronic fetal hypoxia, and sometimes this can lead to fetal death. Then you have intermediate IUGR, which is a combination of symmetrical and asymmetrical. It's typically seen with chronic diseases, and it can occur before or after 32 weeks of gestation. When you look at IUGR, you can see in this baby, this baby has a very large head and a small abdomen and thorax. So remember what I presented to you, the different types. You can have symmetrical and asymmetrical IUGR. The babies that are IUGR and SGA do have common complications. Heat loss. I've said these before, and they're coming back. Heat loss, low blood sugar. They can also have issues with low calcium level. They may have suffered in their history in utero perinatal asphyxia or decreased blood flow, and that can affect their long-term mental development. Here are some of the associated complications of SGA, specifically in IUGR, but irrespective as to whether it's SGA or IUGR, this is what I'm getting at. Some of your interventions are going to be the same. You're going to monitor their vital signs. You're going to watch their temperature and their glucose, and you're going to put in interventions into place to stabilize and maintain this baby. Let's switch gears now and go to the LGA baby, the large for gestational age baby. This is a baby that is greater than 4,000 grams, and there can be different causes for this. It can be a familial history. So maybe this mom just has bigger babies, or let's say she has diabetes. And we talked about the issue with babies who are born to moms who have diabetes, and they typically are bigger. You can have a familial history. You can have mom having a condition such as Beckwith-Weidman syndrome. You can have a baby that has hydrops fetalis, and that's a buildup of fluid. That is sometimes seen in babies with the RH factor that we talked about earlier this semester. There are other factors too. If you have large parents, so the familial history, this is a multi-parous woman, and your male babies are sometimes bigger than your female babies. So we talked about how to classify a baby who's LGA, SGA, or AGA, but babies can also be preterm, term, or post-term, and we talked about the weight classifications. Your babies who are LGA, you're going to have some specific findings. Blood sugar may be an issue for them, but they typically are a bigger baby, but they'll have poor muscle tone and motor skills, and sometimes they just seem very sleepy, and they're difficult to arouse and maintain an alert state. There can be some complications with the delivery of these babies as well. Because they're so big, you have the increased risk of having cephalopelvic disproportion because they're big, so they may have birth trauma issues, or they may have to have a C-section because of their size. They also have an increased risk of asphyxia, meconium aspiration, polycythemia, and hypoglycemia. When you look at the babies specifically, well, they're LGA, but you look at babies born to moms who had diabetes, they may have a more ruddy color. They're going to be a macrosomic infant. They may have excessive adipose tissue, but at the same time, hypoglycemic. So we're going to watch their blood sugar closely. And most hospitals have a protocol as to how often you check their sugar. And they also have increased risk of birth injuries because of their size. So the complications for babies born specifically to mom who had diabetes, we're going to assess them for the development of specific complications such as polycythemia, respiratory distress syndrome, or if they were born with congenital birth defects. You're going to frequently assess their blood sugar. Some facilities may have a requirement that at the time of delivery, some of their cord blood is drawn and sent for laboratory and diagnostic testing. But if that's not your facility's requirement, you may just be required to check their blood sugar per hospital protocol, such as Q4 hours, you're going to check their blood sugar and then feed them. And that may be in place for 24 hours until the baby has 3 consecutive good feeds. If they do not, then they may have you repeat and continue those blood sugar assessments until their blood sugar stabilizes, or they may put them on more frequent feeding schedules. If the baby's blood sugar drops below 40, you want to feed them. Most hospitals, their cutoff is at 40 to 45. You want to feed them, and if they're not able to maintain their sugar above 40, sometimes they will order that the baby, and if the Q3 hour feeds don't work or they don't increase their feeding doesn't work, they may opt to have the baby have an intravenous line placed with some dextrose in their IV solution. Then when you look at hypoglycemia, and this is with all the babies that we just talked about, not just babies whose moms had diabetes, but your small for gestational age babies, your IUGR babies, babies that are LGA. Hypoglycemia is a problem. We talked about this in the normal newborn, but these babies, you want to really get in your noggin that hypoglycemia is a threat to their brain cells, and a blood sugar of less than 30 is harmful to them. So babies, especially the babies that we just talked about, are more prone to developing hypoglycemia, so we have to frequently assess them and implement a treatment plan so that they don't develop hypoglycemia, or early intervention for it. There is evidence-based research out there. Now, this isn't the only research study, but it's one that I particularly found interesting, and that is Malo and the colleagues found and published in Diabetes Care that if during pregnancy we can keep mom's blood sugar at about 95 throughout the 2nd and 3rd trimesters, we can avoid the alterations in fetal growth, such as her developing a macrosomic infant, which can decrease the risk for this baby having transitional hypoglycemic issues. I just found it interesting and thought that evidence-based research does support our interventions and the things that we are trying to do, but you got to watch their sugar.